let's turn to the potential role for surgery, which certainly has a place, at least at some institutions, but it's debatable about how appropriate surgery is for which subgroup of patients with stage 3 disease. This trial, Pacific, was for patients who were considered unresectable, but that isn't really a well-defined entity, and I think it depends largely on the surgeon and certainly the appearance of the scans and the patient. So does the Pacific trial and these more favorable results tip the scale, or do you think that surgery has the same role it always did? And what, if any, is the role for immunotherapy in surgical stage 3A disease? Haas, I'll start with you.
All right. I think this is, again, as was brought up by Charu earlier, this is why you need a multidisciplinary team discussing these patients, looking at the pictures, looking at everything that you have and deciding how to do it. As far as I'm concerned, you decide whether a patient is a surgical candidate or not the day you see the patient in the clinic, seen by all disciplines, and the surgeon says this is a resectable disease, and a patient has the heart and the lung function and everything else to be a resectable patient. Therefore, I'd like to make that decision as much as possible up front. We don't live in a perfect world, and I realize that sometimes things change, but to me, a resectable patient is decided right off the bat, right? I don't like this wishy-washiness of, oh, let's do this and we can take a look. I think those days are gone. We decide whether somebody is a surgical candidate or not, and we go based on that. I don't think we should abandon surgery. I think there's definitely patient population with locally advanced disease who would benefit from the triple therapy that we, chemo, RT followed by surgery. So I don't think we should throw away the surgery for that patient population. And as far as I know, there really isn't any kind of study to say if IO, post-chemo, RT, and radiation is an effective treatment or not. And because these drugs have real toxicities, both financially and in terms of, pneumonitis, colitis, all the other stuff that we know about, for a patient who's gone through surgery, my practice is not to offer IO immediately after that. So my practice is to just enter the follow-up period the way we've been doing it. So, but I'm not ready to do away with surgery, and I'm not offering IO post-surgical resection for locally advanced.
Charu?
Same. Although I feel that, this whole tension that used to exist in our tumor boards about, oh my God, this patient is so close to being resectable, let's take him to the OR, when we used to actually didn't feel comfortable with taking the patient to the OR based on the size of the lymph nodes or the location of the lymph nodes. I think that has decreased for the better. I think we didn't used to do any favors to anyone by trying to take these borderline resectable patients to the OR. Their outcomes did not used to be any better, even if their plan had been established in a multidisciplinary setting at the get-go. I think that's the Pacific data has made the conversation a little more comfortable for everyone involved, where everyone says they're not resectable, let's take them to chemoradiation, let's give them immunotherapy. So I think it's made it much more comfortable, especially with the overall survival data looking as positive as it does.
Yeah, and I agree that if nothing else, that chemoradiation and not going to the OR is not seen as the consolation prize that it was previously. There's plenty to feel positive about. What about for neoadjuvant? We saw some very limited data about neoadjuvant nivolumab, a New England Journal paper by Ford and colleagues, but that was 20 evaluable patients. It looks provocative, but obviously that's not definitive. Does neoadjuvant have any role outside of a trial at this point?
Neoadjuvant IO or just neoadjuvant in general?
No, I'm sorry. Let me say neoadjuvant immunotherapy.
Right.
Not at this time. I think again, very provocative data. I think we have so much to learn in that setting. I love neoadjuvant studies because that's one setting where you're guaranteed paired biopsies or paired tumor samples, and there's just so much to learn that can expand our understanding of how these drugs work and what we can do to improve our response. But clinically, I'm just not convinced that I would want to use it just yet.
I wouldn't do that sort of a trial, but Now, we have intriguing data that's been published, as you suggested, by Ford and colleagues, and we saw a couple of other abstracts presented at World Lung in Canada just recently that, again, the data seems to be good. The data set is small. These are, have to be replicated in a randomized study. But I think we might be looking at a new standard of care by the time these studies are done. At least that's what the preliminary data seems to suggest. But we'll see. But I agree that I wouldn't do it outside of a clinical trial.